Hello, everyone, and welcome to today's webinar, Hemorrhagic Stroke, What You Need to Know About New Additions to Get with the Guidelines Stroke. My name is Sue Abelt, and I'm a program consultant for hemorrhagic stroke with the American Heart Association. Before we get started, I'd like to go over a few items so you know how to participate in today's event. This webinar is being recorded and will be sent via email within 24 hours. There are no CEs associated with this webinar, but you may access a certificate of completion, which will be in a follow-up email after the conclusion of this event. You will have the opportunity to submit text questions by typing them into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Also, a copy of today's PowerPoint slide deck may be downloaded from the handout section. If you experience any technical issues during the presentation, most can be solved by refreshing your browser. If your issue is not resolved following the refresh, please refer to the GoToWebinar customer service team, whose contact information can be found in your webinar confirmation email. And to view live closed captionings for this webinar, please utilize the link in the chat. So let's get started. Next slide. Here's a high-level overview of our agenda for today. We will first level set with an ICH overview, then move into a bit of our AHA hemorrhagic stroke initiative, and then we will really spend the majority of our time today taking a deeper dive into the associated ICH data elements, which are in Get With The Guidelines. And then finally, we'll round out with highlighting some of the great resources which will enhance your stroke toolkits. Next slide. Now we'll just take a moment to introduce our presenters for today. We will hear from Jeannie Luciano, our National Senior Program Manager for Stroke and AFib with the American Heart Association, as well as Jason Walchuk, National Director, Program Development for Health IT at the American Heart Association. So without delay, Jeannie Luciano will be sharing an ICH overview. Jeannie, the floor is yours.
Thank you, Sue, and thank you everyone for taking the time out of, we know you have very busy days, and we're very pleased to have you join us today. So next slide, please, Gino. So why ICH? So intracranial hemorrhage accounts for about 10 to 15% of all strokes and carries a disproportionately high risk of early death and long-term disability. Like I always tell students, it's less common, but much more deadly. And when you talk to patients, and surveys have been done of patients that actually equate severe disability to be even worse than death. Evidence for optimal treatment of ICH has lagged behind that of ischemic stroke. And translation of the guidelines into actionable metrics for data collection will further enhance outcomes for ICH patients. So these improved and enhanced outcomes start with you and in your communities on a local level. So I'd first like to acknowledge the latest guideline around intracranial hemorrhage, the long-awaited guideline everyone was waiting for us to update. Came out in July of 2022 with a very esteemed multidisciplinary group of authors. And this guideline is available not only on heart.org under professional guidelines, but it will also be available on our ICH webpage. I'd also like to acknowledge the group of authors who put together a PowerPoint slides that we will be using some of them today, but also are available for your use as you'd like to socialize the guidelines on your local level. So I'm not going to get too far into the weeds around the class of recommendations and the level of evidence, but applying class of recommendation level of evidence to clinical strategies, interventions, and treatments and diagnostic testing in patient care is sort of the baseline of all of our guidelines. You will see that the class of recommendation can go from a class 1, which would be a strong recommendation, all the way to a class 4, categories that would indicate harm. And as far as levels of quality of evidence, they can go from a level A to a level CEO. If you often see the class of recommendation and the level of evidence are really determined independently, but you will oftentimes see them paired when you look at the recommendations. Then there you go. So when you look at intracranial hemorrhage, so for the purposes of this webinar, we are talking about spontaneous intracranial hemorrhage. So you can see it is once again, a very discrete portion of our overall stroke patients. Our total strokes are upwards of close to 800,000, and ischemic strokes account for about 690,000 of them. Early mortality and morbidity in intracranial hemorrhage is common at about 30 to 40%. We also see significant racial disparities with about a 1.6-fold greater increased incidence of ICH in the Black population rather than the white population. And the same incidence is among Mexican Americans other than non-Hispanic white population. The organization of healthcare systems is increasingly recognized as a key component of optimal stroke care. The guideline recommends development of regional systems that provide initial intracerebral hemorrhage care and the capacity, when appropriate, for rapid transfer to facilities with neurocritical care and neurosurgical capabilities. Next slide, please. So the mechanism of injury, what we know about these patients is they usually come in and they get sick quick. We're often doing multiple serial scans on them. Early hematoma is common and is associated with worse ICH outcome. There is now a range of neuroimaging markers that, along with clinical markers such as time since stroke onset and use of antithrombotic agents, that can help predict the risk of hematoma expansion. These neuroimaging markers include signs that are detectable by non-contrast CT scan, which is the most widely used neuroimaging, the most widely available imaging modality for intracranial hemorrhage. So this is a very wordy slide, and I hate wordy slides, but I sort of like this slide because it sort of walks us through some of the necessary components of the history that we need to get, or the optimal history, right? So we're trying to get the optimal history. Oftentimes these patients come in and we are limited by what we can get from the patient and from the family members or the significant others. So time of onset is important, and we are very tuned in to getting time of onset for our ischemic stroke population. Interestingly enough, in our early project, we found that we were oftentimes missing time of onset in our intracerebral hemorrhage population. We know that we're getting it, we know that we're asking those questions, but it was really a documentation process. Symptoms are important. So did they have seizure on onset? What is their level of consciousness? What are their risk factors? So have they have a previous history of ischemic stroke or hemorrhagic stroke? Are they hypertensive? What are their concomitant medical problems such as diabetes? And do they have a history of cerebral microbleeds? Medications. So medications are really a key component, and we have been saved many times by accurate documentation in the electronic medical records, right? So are they on antithrombotics or anticoagulants? Are they on any vasoconstrictive agents? Are they on antihypertensives or estrogen containing products? Do they have any baseline dementia, often associated with cerebral amyloid angiopathy? So substance use, are they smokers? Do they use alcohol, marijuana? Are they on any drugs, whether they are prescribed drugs or street drugs? And do they have any liver disorders that may be associated with coagulopathy? Next slide, Jean. So outcomes, predictions, and goals of care. So the raft of every stroke coordinator's existence is capturing that ICH score, right? So the decision of when and how to limit life-sustaining treatments after intracranial hemorrhage remains complex and highly dependent on individual preference. The guideline emphasizes the decision to assign a do not resuscitate order is entirely distinct from the decision to limit other medical and surgical interventions and should not be used to do so. On the other hand, the decision to implement an intervention should be shared between the physician and patient or surrogate and should reflect the patient's wishes as best as can be discerned. Baseline severity scales can be useful to provide an overall measure of hemorrhage severity, but really should not be used as the sole basis for limiting life-sustaining treatments. The diagnosis and workup. So as we start everything with our ABCs, so our airway, breathing, and circulation, vital signs really focus a lot around hypertension control, then a general exam and our neurological exam, including but certainly not limited to the NIH stroke scale and the Glasgow coma scale. Labs are nothing really out of the ordinary. We're very focused on glucose control in ischemic stroke, and a lot of that correlates to its hemorrhagic stroke as well. And in the tox screen, I basically say tox screen everybody. In the tox screen, you can find out particular products that they may be using that may have put them at risk. So hemostasis and coagulopathy, and let's talk about complicated slides here. So here's a pretty detailed slide, but it gives you some good information. Intracranial hemorrhage, while anticoagulated, has extremely high mortality and morbidity. This guideline provides updated recommendations for acute reversal of anticoagulation after intracranial hemorrhage, highlighting the use of your protein complex concentrate, your PCC, for reversal of vitamin K antagonists such as warfarin, and Praxbind for reversal of thrombin inhibitor, the thrombin inhibitor dabigatran, and Adexanet alpha for reversal of factor 10 inhibitors such as rivaroxaban, apixaban, and endoxaban. Next slide there. So this is an inpatient care checklist, and this is a population that really good nursing care, not that I'm biased, but really good nursing care is the key to reducing disability and mortality. You want to use the standardized protocols and order sets are recommended. Formal dysphagia screening protocol should be implemented in this patient prior to any oral intake. These patients are particularly at risk because they oftentimes will have decreased level of consciousness and sometimes even fluctuating status. Frequent neurological assessments. The first thing I tell these patients is that we don't often let them get a lot of sleep the first night or so. We're waking them up, checking them frequently. This should start in the ED, particularly on patients who you're planning a transfer from an ED to maybe a comprehensive stroke center, and just really adjust it according to the patient's status and neurological exam. Next slide, please. So medical and neurointensive treatment for ICH. When implementing acute blood pressure lowering after mild to moderate ICH, treatment regimens that limit blood pressure variability and achieve a smooth, sustained blood pressure control appear to reduce hematoma expansion and yield a better functional outcome. So we want to make sure that we're using products that are easily titratable, that you can back off if they start to drop a little bit too abruptly. Rehabilitation and recovery, which is something I think we oftentimes leave out, and we sometimes stop thinking about where they're going from the acute phase. But rehabilitation and recovery are important determinants of ICH outcome and quality of life. The guideline recommends use of coordinated multidisciplinary inpatient team care with early assessment of discharge planning and a goal of early supported discharge for mild to moderate intracranial hemorrhage. Implementation of rehabilitation such as stretching, functional task training may be considered at 24 to 48 hours after moderate ICH. However, and this was a change with the guidelines, early aggressive mobilization within the first 24 hours after ICH appears to worsen 14-day mortality. Multiple randomized trials did not confirm an earlier suggestion that fluoxetine may improve functional recovery after ICH. However, fluoxetine did reduce depression, which we see in both the ischemic and the hemorrhagic population, but it also did increase the risk of fractures. Next slide. So I want to thank everyone for your attention. I'm going to hand you back to Stu to talk about our exciting initiative.
Thank you so much, Jeannie. We really appreciate you sharing the brief science review behind the ICH stroke treatment. So let's move on to discuss our American Heart Association Hemorrhagic Stroke Initiative. Really at the foundation of our Get With the Guidelines stroke registries, it really is a promotion of consistent adherence to our research-driven guidelines. So this allows our hospitals the ability to measure outcome data with the ultimate goal in improving patient care. So to assist in operationalizing these guidelines into actionable metrics, the Hemorrhagic Stroke Initiative was launched to support these efforts. So starting in 2020, we brought together 20 comprehensive stroke centers from around the country. And these hospitals participated in a 3-year collaboration which promoted ICH education, resource development, get with the guidelines, measure testing, and protocol sharing, to just name a few of their joint efforts. Next slide. Here are the 20 phase 1 hospitals. And so you can see that they're from all around the country, and we can't thank them enough for their expertise, enthusiasm, and innovation, which really drove the initiative's success. So then, taking a turn, this success led to the launch of the phase 2 of the Hemorrhagic Stroke Initiative. So this really allowed for a national rollout to expand these offerings to all Get With the Guidelines stroke hospitals. The phase 2 launch took place at this year's International Stroke Conference in Dallas. And so you can see a few of the slides and photos that were taking during this launch. It was a very exciting time. So during the launch, the AHA quality team invited Get With the Guidelines Stroke Hospital to be recognized as early adopters. We really wanted to get the buzz out there and get everyone engaged early on, and many expressed interest. And they really wanted to be involved in adding these ICH measures to their Get With the Guidelines Stroke Registry. So you can see we had a fantastic response taking a look at this map. Within the first week, 309 hospitals answered the call to add these ICH measures to Get With the Guidelines. We now have well over 450 participating hospitals, and this is climbing daily. So again, that map really represented the hospitals, where they were located across the country, just to give you a little flavor. This is our early adopter site characteristics. We just took a look briefly at the bed size of those who participated during that first initial week. And I like this breakdown because it illustrates that the commitment for these enhanced ICH focus is not just from our largest hospitals or CSCs, but are obviously represented here. But we wanted to make sure that no matter what your hospital size, certification or non-certification, this is available to you. So next slide. So as you hear more about the specifics of the ICH measures coming up from Jason, just wanted to provide some details on how to participate if you haven't already. So this ICH measure set includes 10 performance measures and 4 descriptive measures. So the measures that you will see and Get With the Guidelines are based on a 2018 publication on clinical performance measures of the hospitalized ICH patient. And so we do have a link to that article within our research section of this slide deck. So it is available to any active Get With the Guidelines stroke hospital, and you may request this ICH measure just to be added to that registry. There are no additional fees or any contracting involved, so it's quite easy. All you need to do is reach out to your AHA program consultant for healthcare quality, or you can certainly just email our Get With the Guidelines Get With the Guidelines support at heart.org, and we will get you squared away. So next slide. So now we'll just take a turn, and what you really want to hear from is Jason. So the floor is yours, Jason. Thank you.
Thank you, Sue and Jeannie. Just going to share my screen here. All right, thank you. It's great to speak to you all again about this really important and exciting initiative. I see a lot of familiar faces in the chat and in the attendee list. So what we're going to cover today in this section before we get into the Q&A is a brief overview of the layer, what's involved in it, some of the data elements, some of the logic, and then I'll give a brief overview of the incorporated measures within the Get with the Guidelines tool. So to start with, and as Sue just relayed, is that the metrics that we're talking about and the data collection surrounding them are all built based on the most current published clinical performance measures for adults hospitalized with ICH. In 2018, many of the members in the writing committee are members of our system of care advisory group and manage the Get with the Guidelines tool. So it was a great partnership and a collaboration as we started building these and operationalizing them within the tool. If you have any questions on the rationale or background, reference into that document that's shared in the link in the here, and then also in the resource section of this slide deck. So the committee, when they began to review the existing metrics and based on the review, they promoted these 9 specific ICH metrics. They looked across organizations to see if there's some that are similar in design based on their findings, and some that were consistent and adopted. So these are the 9 published measures, but within Get with the Guidelines, we have kind of built upon that and expanded as we've worked with our group, and we'll kind of talk through how that works and what's included in the layer for you all today. So a little bit of background, again, building out this ICH form group was a collaborative effort with the writing committee that published the measures, our system of care advisory group, which manages the Get with the Guidelines data registry. These are all physician and nurse volunteers that work with us. And then our pilot sites, those 20 sites that stepped up and offered to be a part of this initiative to help us develop the layer, develop the data collection, and enhance and refine these metrics for the broader good. That started back in 2019, where we put together a ICH subcommittee that was chaired by Dr. Kevin Sheff. And we began to work through the published measures and then putting them into the Get with the Guidelines language to really operationalize them within the environment. We built out the form group benchmarks, data collection through September, November, and May. We had incremental releases to our pilot sites as they began to look at the data collection and using the metrics. We were giving them feedback, they were giving us feedback. We began to build out better validations, better data collection, refining the elements, refining and improving the measures to really get us to a point in May and January when we released this layer fully into the IRP platform with launch, with some new enhanced data collection and some new metrics surrounding anticoagulant reversal. So it was a very rewarding and deliberate process through the year to really, develop, deploy, test, and then review what we built and continue that cycle that we continue to today. All the feedback and things that you are all providing to us as you onboard onto this layer, we're taking that back, and there are some other future updates that will be coming to enhance and continue to grow and build out this layer. So with all of that work, we settled on currently the ICH layer contains approximately 24 new ICH specific data elements. These elements do operate off of the final clinical diagnosis variable that's within our tool, much like any of the other ischemic stroke Get with the Guidelines variables. They operate off of that final clinical diagnosis of ischemic stroke. These operate off of the final clinical diagnosis of ICH. These elements then have validations attached to them, dependent, as you start abstracting and what metrics they fall into, it'll provide the validation to request that you answer these new elements. For non-ICH patients, the elements may be visible in the form, but the validations attaching to them, requiring them, obviously, are not there. So the form is based, in general, off of the existing hospitals that have stroke and the CSDK or the comprehensive layer. There's 24 additional elements on top of that related to hemorrhagic. So if you do not have the comprehensive layer already, if you have just a smaller form group, the layer can still be applied to you, but you may see a few additional elements that kind of overlap with the comprehensive layer. So you may see a few additional ones beyond that 24. But your quality improvement director from AHA can talk you through all of that and help show the CRFs and what the differences would be. Here's a brief snapshot overview of what the additional data elements that are available and added to the tool in order to operationalize, again, those published measures from the work group. Not all of these are required, and not all of these are required for every single patient. Much like every other data element within Get With The Guidelines, many are conditional. So if you give a reversal agent, for instance, then it will ask the date and time, and it'll also ask what agent you gave. But if you don't, all of those downstream elements will not be required. So it looks like a big list, but it's all dependent on the care provided for that patient and what is being treated. So we do have this broken down into different areas. We added these elements throughout the form so that the data flow, and as you're abstracting, it will naturally be incorporated into sections where you're answering those related things of admission, the dysphagia VT prophylaxis, all the reversal sections been enhanced, and then obviously in the treatment area, that all been added naturally into there. So it's not a separate form or a separate CRF, it's all integrated within your Get With The Guidelines tool. And here are the measures. So we took those 9 published measures from the 2018 published performance measures. Those were the initial launch. Since then, we did enhance these out a little bit more. We added, you can notice there, the second one down on the left-hand side, instead of only having a coagulopathy reversal measure for warfarin and INR greater than 1.4, we actually added a new one for DOAC specific patients. And then if you look on the right, these 4 descriptive measures are not existing in the published measures. These are ways for you to run these to give you information and give you information for quality improvement and the ability for you to do actionable work on areas around coagulopathy reversal, timing of the reversal, and the agents given at your hospital. So a quick, brief overview. I'm going to kind of go through each metric just at a glance. It's in the slide deck, so you have it. Also in the attachments to the webinar, we've also provided a PDF of the Get With The Guidelines ICH published measures within the tool. So you can look at those for the exact logic of what's included for each patient. And it'll also give you an idea of kind of some of those additional data elements that are specific to ICH. But in general, we do have some standard exclusions for all these to kind of answer some of those questions. CMO is addressed in several different measures, but one particular new element that was added as part of the ICH initiative is patients that are on comfort measured or some type of advanced prior to arrival at your hospital. So that's kind of, in the existing CMO data collection model, it's 0 or 1, so it could be anywhere within that 24 hours. This is really beyond that. So anybody that was on it prior to arrival. So with that new element, we do have those additional exclusions for baseline severity, the reversal, and admission unit. Patients that have a stroke after arrival, like many of the other Get With The Guidelines metrics, they're excluded from this patient population as well. Patients not admitted as inpatients, so if you transfer a patient out, they won't be included. If their length of stay is greater than 120 days, it's kind of a standard exclusion, and then clinical trial, as it normally is, will exclude them from the vast majority. Now we'll go into each one. I'm just going to kind of go through the definition here in the denominator and numerator. Again, you have this for reference. So the baseline severity published measure within the 2018 document is percentage of patients with ICH for whom a baseline severity was done and a total score was reported as a part of the initial evaluation. It's really important to understand that this measure does have kind of 2 phases to it. It's within a 6-hour time frame that an initial score for that patient would be done, or if a procedure was done within that 6 hours, the ICH score was done prior to that procedure being done. And that's how it's defined and written in the published measure. And there is, in the published document, there is some rationale and things behind that. So we'll keep moving through. There is a standard exclusion for patients that arrive more than 48 hours after last known well for this measure as well. And obviously, like I said, patients not admitted as inpatients are excluded. The reversal for warfarin, this is very similar to other measures that you had been looking at in the past, but in the Get With the Guidelines and the published ICH measure, it was a little bit more specific, not only the reversal within 90 minutes and vitamin K, but then also the specific reversal agent needed to be looked at. So we added some new data elements where if you give a reversal, you'll choose the reversal agent. That comes into consideration. And there's standard exclusions for patients that receive that procoagulant reversal at a previous hospital, length of stay, again, greater than 120 days. And the denominator is the same, 18 with ICH, arrival within 12 hours of last known well, and warfarin, or INR greater than 1.4. This metric also excludes patients that have a non-warfarin anticoagulant on arrival. It's very similar to, if we go to the next measure, the DOAC measure. This would exclude patients that use a non-DOAC anticoagulant, so it includes just the pure DOAC patients. This also same principle of the timing of within 12 hours. They're on one of the DOACs, and the reversals are given one of the proper reversals for the appropriate or for the specific DOAC that they were on at arrival. Again, within 90 minutes. So there's kind of two parts to the numerator for both the warfarin and for the DOAC reversal measure. It's not only the 90 minutes, but it's also the specific reversal agents. There is a new variable that's added for a reason for not administering a reversal agent, the anti or the DOAC specific reversal agent. So that variable is in there. The coding instructions outline when to use that. Go into the next, VT prophylaxis. There's kind of two standard for the numerator for this. These are all patients with ICH that did not occur after arrival. Patients are admitted as inpatients, and we will look at whether VT was provided or if there was a documented why. Either pass the numerator. Admission unit, this utilizes the new variable that we added. I say new, but I think we added it back in 2019 of the admission unit. That was the reason for this ICH project. So this utilizes that. So now there's a measure for it specifically. So percentage of ICH patients who are admitted to an intensive care unit or a dedicated stroke unit with a physician, nursing, neurosurgeon, acute expertise. So you could look at the measure in the measure document. It'll outline what options in the admission services will pass the numerator. Dysphagia screen within 24 hours. This is a rather straightforward measure. There is a standard exclusion for your patients, obviously ICH, that didn't occur after arrival, and they're admitted. If there's a documented reason why it was not performed, there is a new variable specific to that time frame for 24 hours. So if the patient's in a coma, intubated, any of those other things, then that can be selected. But the numerator is, again, performed within 24 hours or it was done, within 24 hours. And then the second dysphagia measure looks at percentage of patients with ICH who were documented to have passed the most recent screening before oral intake or fluid administration. And this has a two-phase numerator to it. So again, the standard definition or the standard exclusions we see over on the left-hand side, if the patient is NPO during the entire stay, they're excluded, or if the dysphagia screen prior to oral intake is contraindicated, and that's all defined in the coding instructions, or if they fail the dysphagia screen. All of those cases, the patient would be out of this measure. But if they pass through all that and they have the dysphagia screen and they pass, then it goes to was the first oral intake consistent with the dietary recommendations, and you make that answer. Coding instructions are outlined when to choose the options in either of those, but that's a two-phase numerator for this. So it's kind of two different versions of dysphagia. One is the screening initially within 24, and then the second is for those that passed when they got their first oral intake, was it consistent with the dietary recommendations. Blood pressure treatment. We get questions surrounding this blood pressure measure as well. where this takes all your ICH patients, and it basically at discharge, it looks at the final blood pressure prior to discharge, and it looks at is it greater than or equal to 130/80. If they're off medication, so they haven't received any medications, which is a new variable, and their blood pressure is below that 130/80, they pass through. If they don't, if the blood pressure is elevated or they're on medications, then you pass the numerator by prescribing them an appropriate hypertension medication. So it's kind of twofold. Not everybody needs to, and that's the question we get, does everybody need to be prescribed to pass? No, it looks at the blood pressure, and if it's already controlled without medication, then they pass. But if they're not, then you need to prescribe, and that's based on the guideline, the published metrics. Next measure is assessed for rehabilitation. This is, again, excludes patients that are discharged to an acute care hospital, hospice, left AMA, or they're expired, and the numerator is selecting that they were assessed or received rehabilitation services during the hospital stay. Avoidance of corticosteroid use, this is an inverse measure. So this looks at all of your ICH patients and whether a corticosteroid was administered. There is a new variable that's captured within the tool that if there's a reason or rationale for using a corticosteroid for the ICH patients, so if they're asthma, COPD, some other type of reason, you can choose that, and that is an exception. And then the patients that pass into the numerator are the patients that are not treated. All right, so that's a brief overview of the metrics. Again, we have you have the slide deck, and then we also have the guide or the measure descriptions that we provided in the link of the webinar. So the next thing that we wanted to kind of address and talk through as well is that one of the parts of this initiative that will begin to grow over the next year or so is collecting more data on functional status of your ICH patients at 90 days. So with the migration over into IRP, you now have the ability, and there's no restriction on you creating follow-up forms on any patients you choose. We built out that outcomes tab, so it's very simple and straightforward. If you complete a follow-up, you basically answer 2-3 questions, put a modified ranking in, and close it out. There's no other additional elements that need to be captured. We have many hospitals across the country that have already started to do a 90-day modified ranking on their ICH patients. You're going to see more of this over the next year as we provide more help and guidance and instruction. But we wanted to make you aware that it is available in the tool. You can begin to do this and entering these in on any patients that you choose. The big question we get, though, is that, in some of the other measures for certification, they only include ischemic stroke patients that received, thrombolytics or endovascular care. So we do have some get with the guidelines post-discharge measures. We have our 90-day and 30-day modified ranking measure. And these measures, they're distribution. So it just shows you a distribution of your modified ranking of those specific patients that you run it on. Those do include all the final clinical diagnoses. So if you do an ICH, if you do a follow-up on any of your ICH, SAH, and ischemic strokes, obviously, you can run our version of the 90-day modified ranking measure. You can add in a filter for final clinical diagnosis, and you see right here, you can actually filter that down by the different final diagnoses. So you can look at the difference and your modified ranking functional status of your ICH patients versus your ischemic strokes and SAH and so on. As long as you're capturing the data in the follow-up form on that simple outcomes tab, you'll be able to do it on any ones that you want. So that's a nice new feature and a new enhancement. Again, we're going to have more on this coming in the future, but we wanted to make that available and show everyone how that works. All right, we're going to go to one more slide here. So updates that are coming, few things. First, for the two that we didn't talk through here, is that for the based on feedback again and deployment, we do have some updates occurring to 2 of the measures, which won't impact data collection at all, but it's related to the blood pressure discharge and the rehab measure. Those are both going to have the standard exclusions for discharge to an acute care facility. We did have some facilities that admit a patient, but then ultimately transfer them out to another hospital after several days. Those patients were inadvertently falling into the denominator, so we are adding those exclusions in. Again, it'll change the results, won't change in your data collection, but we want to make you aware that those updates will happen. And then also some updates surrounding the new guidelines have been worked through by the volunteers. We are adding some new data elements surrounding blood pressure control. We're going to kind of see and feel out how that new data capture is collected. Will lead to another measure that'll be added into the reports, but we are adding one new measure, which is inappropriate platelet transfusion data collection and a measure. So you can see those coming in the next several months as we have some deployments in the tool. We just want to make you aware of that. And then also in the future, those of you that are part of the initiative or as you come next, there will be a standard ICH form group benchmark that'll allow you to run your hospital and compare yourself to hospitals that are also just participating in that ICH initiative. So I'm going to jump out of here really quick, and I want to address a couple things. I see some questions about the modified Rankin and completing a 90-day follow-up form. So I'm going to show that, and then I'm also going to show one thing in reports for those of you that add this in. So if I go to my patient list, all hospitals now have a standard outcomes follow-up form. Regardless if you've ever had a follow-up form turned on at your hospital in the PMT, it's available now for everyone. So any patient, you could basically grab one off of here. So here's an ICH patient. I could just simply click right here, click add new follow-up form. I could do it from here, or I could actually go into the patient and do it from there. So I could click add new follow-up form. I'll go into the patient and show you where to go from there. If you wanted to add it to this patient again, I could actually click right here in this drop-down in forms and click add new follow-up. So when I do this, my follow-up form is now going to open. And then you see here, I actually have two different layers. So I have a comprehensive site. So I also have the Joint Commission 90-day modified Rankin variable. But right here on the outcomes tab. So this is a hemorrhagic stroke patient. I would not be doing the comprehensive one for Joint Commission because it's not included in that population, but I can still do a post-discharge modified Rankin if I wanted to. So I could put the date the follow-up was done. Yes, a modified Rankin was done. I could put in a date in which it was done. And then I'll just put in my modified Rankin and whether the patient's deceased or not. And that's it. That's as easy and as simple as it is to add your 90-day modified Rankin for your hemorrhagic patients or any patients, that is. These will not fall into any of your Joint Commission measures because those all run off the ICD-10 tables. Ours all work on final clinical diagnosis, so there's no impact or involvement there. I'm going to go into operational reports to answer one more question as well. And if we go down here, you see the ICH bundle because I have that layer. If I expand it out, I can see all of the ICH measures that are included here. And then the follow-up measures that we were referring to, they're not specific to the ICH initiative, but you can open up the procoagulant, or right here, the post-discharge follow-up measures you'll have available, and you'll see that you actually have a 30 and a 90-day modified Rankin. This is the get with the guidelines version of the measure. So you could choose that, and then you could put in here, final clinical diagnosis related to stroke. We could run this for all of 2023, and it will give you a distribution again. If you complete those follow-up forms, you can get a distribution of all of your outcomes, and you can actually stratify the results by the final clinical diagnosis. So you can look at the differences in your functional status at 90 days amongst all of your diagnoses, as long as you complete the follow-up form on them. It's not a rate-based measure. It's not a performance measure. None of these are used for any of that fashion. It's purely for you, for quality improvement, and to provide your team with information about your ICH patients. So I'm going to stop there. I'm going to let this load, and then we can show a little bit more of that. But Kim or Jeannie, I'll hand it over to you. you want to talk through some of the questions.
Okay, so it looks like one of the big questions we're getting is, and Sue, this might be for you, and I can probably help you, but who should get this layer? Is it just for comprehensive stroke centers, or should centers that evaluate these patients in their ED and transfer them out, is this appropriate for them as well?
Thanks, Jeannie. As you could see earlier on when we looked at the site characteristics for our hospitals, it really is available to any site that is interested in taking a closer look at their hemorrhagic stroke patients. And it really informs and moves our data and our quality outcomes. Obviously, the more data and more information we have on these patients, it can inform future work. So great question, but we can have a longer conversation if anyone wants to reach out to their quality consultant to look at your site specifically.
We're getting questions around, and I actually phoned a friend for this. So about how much time does it take to do these additional levels of abstraction? So I have some friends that have used this, and it says it really doesn't change the timing of abstraction. It only involves a few extra data points abstracted from the areas of the chart that they're already looking in. So they don't see it as a large burden of using the additional layer.
And Jeannie, I'll add one. I see a question here from Julie as well that was asking about like the overlap between the measures, but also specifically the data collection around SDK and CSDK. Is that where there was alignment in a need for an element to operationalize one of these measures? So for instance, right, procoagulant reversal agent given, the ICH score, all of those are all existing elements. There's not like two new element, right? The old one for CSDK and then one for us. It's the same element. So a lot of that overlap is there. So as you collect it for your needs for other metrics, you're collecting it for this ICH layer as well. It's just the patients will get routed appropriately into measures based on the IPP in the denominator.
Thanks, Jason. Are you ready to roll, or?
Yeah, I just wanted to kind of show this here. So what I did was I just ran just to kind of show you again, running our 90-day modified Rankin, and this is based on discharge date. This is the get with the guidelines measure. You have your added in final clinical diagnosis related to stroke. And what I did was for comparisons, I just went ahead and selected that final diagnosis. So now at my hospital, I can see the difference buckets of patients that are falling in based on diagnoses. So I could actually go to my measure details and I could look through here. So it looks like 50% of my ICH patients are 0, 33% of my subarachnoid, and so on. So it does give you more data if you go ahead and if you complete follow-ups and complete that 90-day or that modified Rankin variable. You can run these reports and you can actually look at that population that you kind of never could before. So it's kind of nice.
We have a lot of questions around the dysphagia screening in this population. As you know, they are an important population at risk for aspiration. Nursing dysphagia screening tools, most of them have qualifying questions at the beginning. You know, do they have an adequate level of consciousness? What is their O2 set? Are they having trouble handling secretions? So we want to make sure that those, if you are making that assessment and you assess that, you know, I'm not going to offer this patient a sip of water because they are not, you know, awake enough to handle such. That to me counts as doing the screen. You are screening them, deferring and saying, no, they need a formal speech and language assessment. I think Sue wanted to go over some of these things, and then we'll finish out with some questions.
Sure, thank you, Jeannie. Jason, if you wouldn't mind moving back a few slides to that resource. Perfect. Thank you so much. Thanks, Jason, for that great overview. So as we round out our agenda items for today, I wanted to share some specific stroke resources that you might find of benefit. So you may or may not know that the American Heart Association has a mobile app, which is Guidelines on the Go. And this really allows access to the guidelines on your device at any time. So you can download this on an iOS or an Android. So this app integrates all the clinical treatment guidelines and allows for you to easily search any of your resources you need, and it's right at your fingertips. So just wanted to give that plug if you hadn't already been aware of that. On our next slide, we have a link to our heart.org.quality site. So you can go to the next slide. And there is a link to our hemorrhagic stroke initiative, has some great resources, and we're continuously adding to that link. And then moving on, if you could advance to our stroke month information. One more. Thanks. As we prepare for American Stroke Month in May, which is actually next week, crazy enough, we want to assist our hospitals and organizations around the country to spread awareness of stroke. And so our teams have really assembled a fantastic toolkit which supports your Stroke Month programming. There's lots of great content to be found here for both professional and patient-facing needs. And then as we continue on Stroke Month, we have a wonderful webinar series coming up. So next slide. So in May, next week, we do have a webinar that discusses stroke hub and spokes, keeping the wheels turning. And then following that, on the next slide, we do have a really wonderful topic about stroke support groups, strategies, and lessons. And then finally, our very coveted and well-attended Get With the Guidelines Stroke customer office hours is on May 23rd. So please register for those, and we really hope that you can join us and continue our education journey in the month of May. So, and then last day here are just links to the reference science from today's webinar. So just to connect again, Jeannie, is there any other outstanding questions that we might want to address?
There is, and if you put a question, and we answered a lot of them in the question pane. So there is a great question here. When will all these measures be permanently added to the IRP? Right now it's early adoption, but will this be mandatory or permanent in 2024? Not mandatory, but I think I'm going to go out on a limb by making the executive decision that right now we consider them a permanent addition to our tool. Jason, would you concur?
Yeah, I agree.
Okay.
And you will be seeing a lot of things with ICH and a big focus on hemorrhagic over the next several years from the AHA. This is kind of the first step, the first phase. We're rolling these out. Again, it's an optional opt-in layer, just like think of it like the endovascular layer for Get With the Guidelines. That's another optional layer that gives you a significant number of additional measures for your quality improvement purposes, but we're really looking like we do with most of the Get With the Guidelines data collection, is that this is one of the most rich and valuable data sets for acute stroke care in the world, really. And we need better science, we need better information and data surrounding the treatment and care for these ICH patients. So by joining this layer and contributing to the data set, it will go into the national data set that will then be able to be used for future publications and better guideline development. So we're really excited about it, but that again is always something in the background. Participating in these registries it goes beyond just quality improvement at your facility as well. It also contributes to those broader guideline developments that will be coming in the future.
There is a request for Jason's slides to go out. I will tell you that you will get a recording. You'll be able to access the recording of this webinar. It will be on our ICH website, and I think it comes out with the follow-up email as well. So you'll be able to see all that. He was in the tool, so working with the tool, so it was not a slide. Just shows you how wonderful the tool is that he could run the data that quickly. There is a couple questions about cost, and once again, there is no cost related to this this layer. I'm trying to work my way through here.
And there is no cost.
No.
No cost or no contracting at all.
Yep.
It's an easy
Basically,
ask.
Yep, you could basically request it from your QI consultant. It'll come to my team and we'll turn that layer on.
So there is a question about will the 30 or 90-day follow-ups be considered be mandatory? And the answer is no. It is something that we see, as with a lot of things in ICH, as a gap, that we often don't have that follow-up information on patient outcomes for this population. So I think it's a wonderful opportunity for a quality improvement initiative at your sites. And maybe we're looking at some options from a overall standpoint, but I think it's a wonderful opportunity to gain further information and to be able to capture it on the form so that you can use that information for your internal quality improvement as well as, you know, research initiatives. And Sue, I'm going to hand it to you to finish this out.
Great, thank you. I will share a few thoughts. So I just really want to thank Jeannie and Jason and Gina Malika and Kim Chapoy-Casas, who are on the back end behind the scenes, for sharing your time and expertise today as we learn more about these really wonderful enhancements to our American Heart Association Get With the Guidelines Stroke Registry. And really thank you very much to everyone for attending. It really showed that we had great registration, which is very exciting. So it tells us that you're very interested in this topic, and we continue to look forward to bringing you more content. So once you leave today's webinar, you'll receive an email with a short survey, and we'd really appreciate it if you'd give us a complete and provide some of that feedback for us. And you'll receive a follow-up email within 24 to 48 hours to view the recording of today's webinar. And as a reminder, the slide deck is in your handout section, and we will share that as well. So on behalf of the American Heart Association and our presenters today, thank you for joining us. We really appreciate it, and enjoy the rest of your week. Take care.